Assalamu alaikum. Today I'm going to deliver a simple and elaborate as well the lecture on laparoscopic nephrectomy. I know there's nothing new in it, and it is just a repetition of what we have already discussed in various videos, as well as you must have read it in various books, and a lot of people teach it. So, however, I would like to simplify the process and the procedure as much as I can. So we begin with the name of Allah, the Almighty. This is a lecture which I'm recording for on the advanced laparoscopy. I'm Dr. Akhtar Nawaz, as you all know. So, what are the indications of nephrectomy? The nephrectomy is basically the removal of kidney from the body. The indications can be a non-functioning kidney. Not every non-functioning kidney needs to be removed from the body. However, there are certain indications to it. Let's say, for example, if it is symptomatic, it is painful, the patient feels pain every now and then, and it is disturbing his or her day-to-day routine activities, then a non-functioning kidney needs a removal. If the kidney is hydronephrotic, or if it is a pyonephrotic secondary to some causes, like for example, if there is ureteric stricture, there is PUG obstruction, and the kidney has gone hydronephrotic, and there is a reduction in the cortex, there is cortical loss, parenchymal loss, and the routine functions, the DTPA scan or the DMSA scan shows that the kidney is non-functioning or the parenchyma is non-functioning and it is hydronephrotic, then it needs to be removed. And if there is a kidney and there is a stone in it, so it has to be removed because it can become symptomatic. The stone can drop down into the ureter, leading to hydronephrosis and pyonephrosis, as well as this stone can grow, and stone is a good source of infection, so it can lead to infection as well, leading to complications. Then there is another indication for a non-functioning kidney. Let's say, for example, if a patient is having a small scarred kidney, it is non-functioning as well, and the patient is having hypertension because the body is sensing it, that there is, let's say, for example, there is a scenario of renal artery stenosis where their kidney is non-functioning, but the hypertension is so much so that it can affect the other kidney, and it is not controlled with routine 2 or 3 drugs. Then in this case, this kidney needs to be removed, even if it is a poorly functioning kidney as well. Then grade 5 renal trauma is again an indication for nephrectomy. Then, of course, radical nephrectomy, removal of the kidney secondary to presence of a tumor. That tumor could be, it is not a lecture on the renal tumors and its types. However, various tumors can be dealt with differently. Nowadays, the incidence of renal tumors have increased because of the better access to health, better access to better imaging, and so the incidentuloma has gone up, and the incidence has gone up. So, but these incidentulomas are usually 5-6 centimeters or lower, so partial nephrectomy can be performed. So radical nephrectomy, the numbers have decreased. However, still there are a lot of patients who require radical nephrectomy in the form of removal of this tumor along with the kidney. Another indication is the donor nephrectomy for end-stage renal disease patient who requires renal transplant. The advantages of laparoscopic nephrectomy. There are a lot of advantages. It has been long since laparoscopy is in picture. However, Europe and America and the most advanced nations, they have gone towards a better form of laparoscopy, which is robot-assisted laparoscopic surgery. However, we are still in that era where we are developing laparoscopy. So the advantages of laparoscopy over the open surgery are: number one, a better cosmesis, because let's say, for example, a non-functioning kidney is removed from the body. It will be removed through a smaller incision, usually 3 centimeter, or even 2 centimeter, or even 4 centimeter. So it leads to better cosmesis, and there are small incisions which heal better and giving rise to better scars rather than one huge scar. The operative time is less. Initially, during the learning curve, the operative time may be more as compared to the open surgery. However, even in open surgery, if one is going through the learning curve, the operating time is long. So when a surgeon becomes expert in open surgery and he passes through the learning curve, his operative time shortens. Same is the case here in laparoscopy. That one reaches its learning curve, the operative time significantly reduces. However, it is worth here to mention that the vision is better, everything is magnified, you can control the hilum very easily as compared to the open surgery. So the hemostasis is meticulous, so there may be less chances of spending more time during the operation. There is a reduced amount of blood loss, as I already mentioned, that even a small vessel in millimeters will be visualized, magnified. So one is tempted to coagulate that, while in the open surgery that is usually overlooked, and so the blood loss is more as compared to in the open surgery, the blood loss is more, while in laparoscopic surgery it is less. So there is lesser need for blood transfusion because the blood loss is less, and blood is lost in opening the skin, the subcutaneous tissue. The muscles are cut and incised, and they lead to a lot of bleeding. So the blood loss is less, and the patient usually requires lesser blood transfusions. The post-operative analgesia is less as compared to open surgery because the wound is big, number one. So bigger wound will be aching more. In laparoscopy, there are more wounds, but they are of a smaller size. So smaller sized wounds will be less painful. These are two factors. Number third is the retraction. In open surgery, one usually needs retraction, and in nephrectomy, whether that is a subcostal incision, a supracostal incision, the requirement for retraction by the devers and other retractors, and the self-retaining retractors, they usually compress the rib, and they also compress the muscle, leading to muscle ischemia, and that is usually more painful as compared to laparoscopic surgery. And this we have published this in our article as well, whereas there have been a lot of publications that the analgesia requirement is less as compared to open surgery. Patient can be mobilized early. You can operate in the morning and get the patient mobilized in the evening. And early oral feed can be given because there is less pain if the patient is mobilized, the blood loss is less, operative time is less. So patients' peristaltic movement of the gut are usually returned early, so a patient can be orally allowed. And there is early return home and early return to work as compared to open surgery because of all the factors mentioned in this row. Then the less operative time and post-operative complications on the right hand. These are some references taken from various articles, which also show, and they also second our our arguments on the left side, the advantages, and it is better tolerated by interstitial disease patients as compared to open surgery. In some cases of kidney transplants, we have to remove the native kidney, maybe due to scarring, maybe due to hydronephrosis, maybe some other pathology, or a reflux disease. So that kidney cannot stay in the recipient, and we cannot proceed with the transplant. So we have to go for nephrectomy in such cases. And this nephrectomy is tolerated by the end-stage renal disease patients better as compared to open surgery. Sorry. The donor nephrectomies have similar graft outcomes. There are few arguments regarding the donor nephrectomies. The first one is the warm ischemia time. That can be reduced significantly. I have seen in many centers it doesn't contribute much. However, it may be a little longer as compared to the open surgery, because in open donor nephrectomy, you immediately shift the kidney to the eyes, whereas in the laparoscopic donor nephrectomy, you may have to get your hand in and then extract the kidney and shift it. So there might be a difference of around 15 to 30 seconds. And that doesn't usually affect the outcomes of the graft. This is one thing. The second important thing which people usually argue about the donor nephrectomy is that in open donor nephrectomy, you can take longer vessels, whereas in the laparoscopic surgery, you have to apply a stapler device, and those staples then have to be excised on the bench. However, I have seen quite a few and attended and assisted quite a few laparoscopic donor nephrectomies. I have practically never seen this issue with the length of the vessels. Same day discharge as a day care surgery is possible, as is possible in laparoscopic cholecystectomy. They say that if you are performing an open surgery, even a hand-assisted laparoscopic surgery is better than two hands hand-assisted. And nowadays, even single-site laparoscopic surgery is also very much famous, especially in the face of development of the robot assistants. The disadvantages, yes, of course, every procedure has got its disadvantages as well. So laparoscopy is also not without disadvantages. The topmost disadvantage is the anesthesia. Laparoscopy cannot be performed in local or in, for that matter, spinal anesthesia. It has to be general anesthesia. And why general anesthesia is required, for that we will have a separate lecture to explain why is that required. So general anesthesia is required, number one. Number two, good monitoring by the anesthetist is required of the patient. And pneumoperitoneum has to be created, and pneumoperitoneum has got its own disadvantages, like hypercapnia, hypercarbia. This can lead to various complications which are particularly related to the pneumoperitoneum. So we have planned a lecture on this pneumoperitoneum and its pathophysiological and pathological effects on the peritoneum and the patient. For that, we will record a separate lecture. So this is a disadvantage, and a lot of equipment for is required for laparoscopy, like in the form of capnometry, like in the form of visual system. So there has to be a good system, which is a 3-chip camera, a high definition camera. Even nowadays 4K visual systems are available, and if it is a 3D visual system, it is a very advantageous. However, it will really be expensive. So a good insufflator is required. And there are various kinds of energy devices need to be made available in laparoscopy, like harmonic, like ligashore, like the stapling devices. So all these lead to increased costs, which are really very important in our part of the world. Then is the learning curve. Every procedure in life has got a learning curve. Driving has got a learning curve. Cooking has got a learning curve. Surgical procedures, open procedures have learning curves. Endoscopic procedures have learning curves. So there is a learning curve for laparoscopy as well, and that usually is around 30 to 35 cases. Once the surgeon goes through that learning curve properly, then he becomes expert, and all the advantages can be achieved as mentioned in the previous slide. And there are some complications which are specifically related to laparoscopic surgery, which will be discussed in the lecture on complications of laparoscopic surgery. So now we come to the real topic of nephrectomy. So first we are discussing the right nephrectomy. We will discuss the differences between left and right nephrectomy in the same session, and the simple and radical nephrectomy in the same session as well, because there are very minimal differences between left-right and the radical and simple nephrectomies. So patient has been anesthetized. Then a nasogastric tube is a must in every laparoscopic intraperitoneal or transperitoneal surgery, so as to avoid any injury to the stomach by the first trocar. So nasogastric tube is placed, and then Foley's catheter is placed to empty the bladder, so that to avoid injury to the bladder in the first trocar. And then comes the position. The position of the patient is the usual position. I will show in the diagram in the next slide as well. However, the position that I prefer is a straight lateral position. It may be 90-degree tilt, it may be a 45-degree tilt, or it may be a 30-degree tilt. But the patient has to be strictly on the edge of the table, so that the belly of the patient drops down and it takes away all the gut and momentum along with it. Because if the patient is lying on the center of the table or the opposite edge of the table, then the belly will be lying on the table, and it will not accommodate, it will not make the gut and everything fall down. So if the belly is big, the patient has to be on the edge of the table. But the disadvantage of this position is that if the patient needs conversion, then it's difficult for the surgeon to come back, and the patient is on the opposite edge of the table. So I think that is the procedure becomes really cumbersome, and that is a disadvantage of this position. But the advantage of this position is that the patient is straight. So the bridge that we usually place under the lower side of the bag, that causes pain on the same and the opposite side after the surgery. However, if the patient is straight, that pain is gone. This is one disadvantage. And the second disadvantage I told you is that the belly is dropped down, so it takes away momentum and all the small bowel away along with it, and one can easily perform pneumoperitoneum and the procedure. However, this thing can be the surgeon's preference. Some people like the conventional left lateral or decubitus position, and some would prefer this position that I have described. It has happened to me that quite a few times I had to convert the patient, and usually we were performing in two cases. We were performing simple nephrectomy, and one case we were performing a pyelolithotomy and a pyeloplasty, and we had to convert. So there was no big issue in converting the patient in the same position and dealing with the pathology from the same side, rather than going to the back of the patient. Then pneumoperitoneum is created. The creation of pneumoperitoneum is a topic that requires a separate explanation and description, and we'll be arranging that soon. Then is the port placement. The port placement for a right-sided nephrectomy, there are 2 or 3 methods of placing the ports, which will be described in the coming slides. However, there has to be one camera port, there has to be one working port depending on the surgeon, whether it's left-handed or right-handed, and there has to be one assistant port. However, for the right side, an extra port is required in the epigastrium, either to lift and retract the liver, or in the subcostal region for the fan retractor or the snake retractor. And the specimen can be then extracted by combining the two port sites. Like, for example, the right-handed working port with the camera port, or the camera port with the left-handed assistant port, or the working port, or between the two working ports horizontally. That will be explained in later slides. So these are the relations of the kidney on the right side, the suprarenal gland, and there is hepatic area, the duodenal area, and the colonic area. Here it is worth mentioning that there are two important structures. Number one is colon, and number two is the duodenum. These relations have to be kept in mind while mobilizing the kidney. The colon is covering the lower portion of the anterior surface of the kidney only, while in the left side the relations are different, as can be seen in the diagram. And these are the simple things which can be seen: the adrenal gland, the right renal vein draining into the inferior vena cava, and the renal artery coming behind the inferior vena cava to the kidney from the aorta. And on the left side, the left renal vein is crossing the anterior surface of the aorta towards the inferior vena cava. An important structure is the superior mesenteric artery, which may be crossing anterior to the left renal vein. The gonadal vein on the left side and the adrenal vein, they are draining into the renal vein, so they have to be kept in mind if you're performing a radical nephrectomy or radical nephrovitrectomy. Then of course they have to be kept into account and need to be taken down before clamping the vein. While on the right side, the gonadal vein is going directly into the inferior vena cava. And this is really important because if you are performing left-sided nephrectomy, you may lift the gonadal vein and ureter complex together and move along the gonadal vein towards the hilum, whereas on the right side you have to go lateral to the gonadal vein, because if you are lifting the gonadal vein, there may be avulsion of the gonadal vein from the IVC, and that can lead to severe torrential bleed, which may or may not be able to control, and that may lead to conversion of the procedure from laparoscopy to open. However, this should be kept in mind that on the right side you have to go lateral to the gonadal vein rather than medial to it. This is the position that I was talking about. As you can see, that the patient is really heavy, and the belly is really dropping down, hanging from the table, and the patient is on the edge of the table. The left forearm of the patient is also kept away from the field, and the patient is fixed and padded. And this is the position for the right-sided nephrectomy, the same as described in the previous. Here you can see again that the patient is catheterized and is fully covered. Prophylaxis for DVT has been done, and the table is broken. And this is the typical position, which is called right decubitus position. However, as seen in the previous picture, like this one, the patient can be placed in a straight position rather than breaking the table. Depends upon the preferences of the surgeon. Then we come to the port placement. There are quite a few sites and methods of placement. Number one is the baseball diamond technique. Here you can see that there is a diamond-shaped field in the baseball court. So on the right-hand side, you can see that the target organ is on the tip of the index fingers, whereas you make the diamond then, and the thumbs are on the area where you will place an optical port, or it can be a working port for you, and then the anatomical snuff boxes are for the working port. So this will be baseball diamond technique. And the circular technique, it is for the pelvis. However, the same can be applied for the left or the right nephrectomy as well. The red point is the center, which is the target organ, and then you draw an 18 centimeter line and then a 24 centimeter line. The optical port can be on the 24 centimeter line or in the 18 centimeter line. However, the working port has to be on the 18 centimeter, because in that way you can create a good ergonomic lever of the working ports, because the usual length of the standard length of the instruments, laparoscopic instruments, is 36 centimeter. So 18 centimeter would make it half, so creating a perfect lever for optimal function. This is another technique. Here you can see that this is a right-sided post-nephrectomy patient on the left side. So there is a perfect triangle. One can see that the tip of this triangle, the upper peak, is on the organ, is the target organ, which is the right kidney, and it is on the just one finger bit below the tip of the ninth rib. And then there is a 7 centimeter gap between the optical port and the right-handed working port, and 7 centimeter distance between the left-handed working port and the optical port, and in between the two vertical ports the distance is 10 centimeter. I'll show in the diagram. However, I will show in the video as well that your four finger breadth for example, this is the visual point. So 4 finger breadth below the optical point here is the one working port, and then 4 finger breadth here is another port, and then our complete hand has got 10 centimeter distance between the two working ports. So this creates a perfect angle of 60 degree, and which is the angle of manipulation, and it is very good for dissection. It is very good for triangulation for the suturing as well. So initially I used the baseball diamond technique during my learning curve, but once I went through the learning curve and I started this port placement, the triangular port placement, which is usually propagated by Professor Dr. Reno Bollins, it really became easy, especially for nephrectomy and vesicovaginal fistula, the pyeloplasty, partial nephrectomy, renal cyst, adrenalectomy. For all these procedures, it was a perfect port placement. So same can be seen on the right hand side. You can see that I usually retrieve the specimen through the camera port, because it is very near to the subcostal region and leads to minimal chances of incisional hernia. However, it is a little more painful as compared to lower down scars, but pain can go away after a few weeks. However, incisional hernia can be a problem. So I usually prefer to remove the specimen through that port. However, if the specimen is large, if you have performed a radical nephrectomy, because in simple nephrectomy we deflate the kidney, or we may remove it piecemeal through the same small ports, but a radical nephrectomy will require a larger incision as compared to the scar for the small kidney. So the two ports can be combined, either the optical in the right port, the optical or the left port, which is not really good. However, the right-handed port is better because it becomes subcostal, or you can go and combine the two working ports, which will become a right paramedian incision, and the drain can be can be placed in the assistant port. So this is something about the port placements. Then the steps of nephrectomy. Number one is the identification of anatomy. You have to see within the peritoneum what's going around. Then is mobilization of the colon, and these are the pet steps, because everyone has to follow these steps, especially during the learning curve. If you follow these steps, you will be avoiding a lot of inadvertent effects and complications. And if you follow the same steps again and again and again, you will become faster, and your operative time will become shorter, and the pneumoperitoneum will become shorter, and the complications post-operatively and peroperatively will become less. So these steps have to be followed in each and every case of simple nephrectomy, of radical nephrectomy. So there is identification of anatomy, there is mobilization of the colon, identification of ureter, dissection of the lower pole, dissection of the pedicle, dissection of upper pole, dissection of posterior surface. All these will be explained one by one. So topmost is the anatomy on the right side of the liver. You have to see how much is the liver covering. From the relations of the kidney seen in the previous slide, we saw that the duodenum was important on the right side. The lower pole, the colon, was really important, and also the area covered by the liver was really important. So these can be seen when you go in and create pneumoperitoneum and you place your ports in. You will see this, how much is it covering. Where is the stomach? Is it distended or deflated? If it is still distended, you need to place and replace the nasogastric tube to decompress it. And you have to see where is the colon. In a few of my videos, you might have seen, especially in the latest video, the liver was adherent to all the colon. It was the transverse colon, not the descending colon, but it was all along the edge of the liver. So first we had to mobilize that colon from the edge of the liver, and then we had to mobilize the liver and lift it, and then we had to mobilize the colon. So you have to see how much is the colon covering, where is the omentum, where is the gallbladder, and where is the liver. Is it big? Is it small? How much is it covering the kidney? So after seeing this, you will make a plan. Okay, then you place an extra port in the bigestem to lift the liver. Or, as I already mentioned previously, that you have to place another port in the subcostal region to lift the liver through a snake retractor or the fan retractor. I personally do not use a snake or fan retractor. I use that same retractor. I go through epigastrium and then lift the liver and retract it. So then you have to mobilize the hepatic flexure, keeping in view the planes. The trick to laparoscopy is going through the planes. If you are not going through the plane, laparoscopy becomes extremely difficult, because all the field will be red and structures are difficult to identify. So to identify the structures, you have to go through the anatomically avascular planes. So that, do we have to mobilize the colon? You have to mobilize it up till the pelvic brim, and medially as much as that you are able to see the gonadal vein on the right side, and especially also on the left side as well. So you have to mobilize the ascending colon, and on the left side you have to mobilize the descending colon. In case of nephroureterectomy, you may have to mobilize the colon more. But however, you can see on the right side that The colon is ascending colon starts from the cecum, and the cecum usually ends at the pelvic brim. So once you reflect the cecum, there is no colon, so you have to go along the ureter towards below the pelvic brim. But on the left side there is sigmoid colon, and that has to be mobilized medially up till the bladder and below the sacroiliac joint or the pelvic brim. While on superior side, on the right side, you don't have to mobilize the colon much. However, on the left side, one has to mobilize the colon along with the spleen up to the left crurum of the diaphragm, so that the spleen drops down and it takes away all the colon along with it, because otherwise you will have to need another retractor, and retraction in this area near to the spleen may be a little bit dangerous, because it may cause rupture of the spleen and bleeding. So after mobilization of the colon, you have to identify the ureter. Ureter is usually, that's why I said that you have to go in the anatomical planes. If you are in the anatomical planes, it is usually easy to identify structures, and the ureter is identified by its peristaltic movements. So you grab the ureter, and it is usually in the posterior plane. It is lateral to the gonadal vein in the proximal portion. However, it crosses at the pelvic brim and becomes medial distal portion. So it's usually better to identify it as proximal as possible, and usually dissect it lateral to the gonadal vein and make a window between the gonadal vein and the ureter, and this will lead you towards the psoas muscle posteriorly. And then the ureter can be slinged and the sling can be brought out through the skin, and one can grab it, or you can place another assistant port which can do suction, which can do retraction, and which can lift the kidney for you, lift the lower pole of the kidney for you in this window. So then slowly and gradually along the lateral surface of the vena cava in the gonadal vein, we dissect and coagulate and cut, and we reach up to the hilum, making the window bigger and bigger bit by bit. Then comes the dissection of the pedicle. The vein is usually anterior. However, the artery, it can be posterior superior, it can be totally posterior, or it can be posterior inferior. Number of arteries can be single, or it can be double. Veins can be single, double, or even triple. So you have to be really vigilant to dissect all the arteries and veins. At times on the right side there are, or even on the left side, there are separate arteries from the aorta towards the lower pole. That needs to be diagnosed, especially in cases of non-functioning kidneys secondary to neglected PUJ obstruction. There are usually lower polar vessels, so those vessels should not be missed, otherwise there's a lot of problem. So there are a lot of variations. However, the most common site for the artery is the posterior inferior in 90% of the cases, I would say, or 85% of the cases. However, in 5 to 10 to 15% of the cases, it can be either posterior or even posterior superior, and that has to be kept in mind, and those have to be dissected and taken care of. Once you dissect the pedicle, dissect the artery and the vein separately, and then you dissect the artery enough to apply one clip, and so that the circulation to the kidney is reduced. And then the second thing is to do the vein. Then you do the vein, you apply 2 clips proximally towards the major vein on the vein, and 1 clip distally towards the kidney, and then you divide the vein. After division of the vein, then as you have already applied 1 clip on the artery, then you can dissect the artery properly, because as I mentioned earlier, that the artery is always posterior. It may be inferior or it may be superior, but it is always posterior. So once you go through the vein, cut it, and the vein retracts, and then you can go and dissect and clip the artery and then divide it. However, there are various methods of doing this pedicle. Number one is clipping. Clipping can be metallic clips, and they can be hemalock clips. And one can use metallic staplers devices as well, but are very expensive. However, in certain cases where you cannot dissect between the artery and the vein, then you can apply the vascular staplers to the hilum in toto. Intracorporeal, extracorporeal suture ligation can also be performed, and depends on the surgeon preferences. However, nowadays the procedure which is in fashion is hemalock clips. Then after doing the hilum, you have to dissect the upper pole. And dissection of the upper pole, you have to follow the upper pole in simple nephrectomy. This is the difference between the simple and the radical nephrectomy. In simple nephrectomy, you have to follow the upper pole of the kidney. So you will be dissecting between the adrenal gland and the kidney. There are exchanges of small vessels between the renal capsule, the garota, and the adrenal. So these vessels may lead to bleed and can make the field dirty and red and procedure difficult. So those have to be kept in mind. And in order to control those, you have to go horizontally, bit by bit, from parenchyma to the upper pole of the kidney along the parenchyma, horizontally, not vertically. If you are going horizontally, slowly and gradually, plane will be defined between the adrenal gland and the upper pole, and hence the bleeding can be avoided. However, if you are performing a radical nephrectomy and you have to remove the adrenal as well, as we all know that the indication of adrenalectomy in a radical nephrectomy is only the involvement or direct invasion or the upper pole tumor. Nowadays, in the mid pole or the lower pole, removal of the adrenal is not really necessary. However, if you have to do it, then you have to follow the psoas muscle rather than following the upper pole of the kidney. And once you follow the psoas muscle up to the liver and up to the spleen on the left side, then you will see that you have been able to take down the adrenal gland as well. On the right side, by taking the adrenal gland, there is a very short adrenal vein which is draining the adrenal directly into the IVC. It is really very short, less than 1 centimeter, and it is usually located on the posterior side or the posterolateral side of the inferior vena cava, and that vein needs to be clipped before fiddling with the adrenal gland. While on the left side, there is a big and a longer adrenal vein which is draining into the renal vein, and there is an artery which is coming from the inferior phrenic artery. There is an artery which is going directly from the aorta into the left adrenal gland, and a branch is coming from the upper pole branch of the kidney towards the adrenal. So all these vessels need to be addressed while performing a radical nephrectomy along with adrenalectomy. Then once we are done with the upper pole, then what you do is that you lift the kidney. You lift the kidney and you dissect the posterior surface as much as possible. They say that there is a 5 minutes procedure now to remove the kidney, and there is a 20 minutes procedure to remove the kidney. The 20 minutes procedure is that after doing upper pole, you start mobilizing the kidney from the lateral aspect and mobilizing it medially. But that is really dangerous, because on the right side you will be making the kidney fall on the IVC, while on the left side you're making the kidney fall on the aorta, and slowly and gradually you will be over the aorta and IVC and dissecting the tissue that may lead to injury to the major vessels, and it will take a lot of time. However, this 5 minutes method is that you lift the kidney and you dissect posteriorly to the extent as much as possible, so that only the peritoneal layer is remaining. The rest of the tissue is mobilized from the psoas muscle and the posterior abdominal wall muscles. And once you do that, and then you leave the kidney, it drops down again, and then it becomes a piece of cake for you, because you have to just cut the peritoneum and all the kidney will be mobilized. Clipping the ureter or cutting the ureter is very simple. It's not really difficult. You can clip it, you can ligate it, you can only just cut it with a ligature, and but the important thing is that it depends on the pathology, whether there is transition cell carcinoma, whether there is renal cell carcinoma, or there is a refluxing ureter, or there is a ureter stone in the distal ureter, and there's a non-functioning kidney, and so you have to remove that stone as well. Or if you are not removing that stone, then you have to cut the ureter, suck all the residual urine in the ureter, and then ligate it. Or it may be a refluxing ureter, so you have to clip or ligate that distal portion of the ureter. The proximal portion can also be clipped or ligatured or harmonic. Okay, dissection of the convex border. I said it becomes a piece of cake because just a layer of peritoneum is remaining, so you have to cut that, and the nephrectomy is then performed. Then there is removal of the specimen. Bag can be used to remove the kidney as a whole, like in the radical nephrectomy, but in non-functioning kidney, bag is really not really required. So what you do with the kidney is hydronephrotic. You can just deflate the kidney, it will become smaller. You can increase your port site a little bit more to, if it is 1 centimeter, make it 2 or 3 or even 4 centimeter. You can remove the kidney. Or if it is a non-functioning kidney, you can remove it piecemeal. However, previously morcellation was used very frequently, but after complications its use has become quite less now. So you can remove through various incisions. Here you can see that the kidney has been removed through various kinds of incisions. You can see here on the left side that the nephrectomy was performed. Actually, nephrouretrectomy was performed for a non-functioning kidney due to distal ureteric stone, and then the kidney was placed in the left iliac fossa, and the left iliac fossa was then opened to retrieve the kidney as well as deal with the stone lower down. And in the second incision, you can see that it was a lady who was having a huge 14 centimeter ovarian cyst on the left side, and she had a left-sided non-functioning kidney. So we performed laparoscopic nephrectomy, and we placed the specimen in the pelvis, and then we removed the specimen through Fenton steel incision and also dealt with the ovarian cyst. And then is the radical nephrectomy. You can see that it has been, the camera port site has been enlarged to remove a large specimen of radical nephrectomy. And then is the nephrouretrectomy for radical nephrouretrectomy for upper tract TCC. Again, has been removed through left iliac fossa, as we also dealt with the distal ureter. So different incisions and sites can be used. In Europe and America, for a non-functioning kidney or a donor nephrectomy, in the female, removal through the natural orifice like the vaginal vault is also in fashion. The complications of nephrectomy can be bowel injury. On the right side, one can injure the duodenum, the hepatic flexure and ascending colon, while on the left side, the descending colon can be injured, and jejunum can be injured as well. In vascular complications, you can injure IVC on the right side, gonadal vein on the right side. As I mentioned, that you should not lift the gonadal vein along with the ureter, because that may lead to avulsion. And renal vein can be injured in various fashions. Arterial complications are usually not very common, but renal artery or aorta can be injured. All these complications will be discussed in a separate section on complications of laparoscopy and their management. So the risk factors for complications are poor recognition of anatomical landmarks. If the kidney is, especially on the left side, superior mesenteric artery, inferior mesenteric, right renal artery, the splenic artery, the aorta can be injured, especially if the kidney is chronically hydronephrotic. If there is a stone stuck at the PUJ and kidney had been there and had been inflamed for quite a long time, there has been repeated attacks of pyelonephritis, and there has been a placement of a percutaneous nephrostomy, etc. In such cases, usually the things are really foggy, so a lot of complications can happen. Superior mesenteric artery, while going for the left renal vein, superior mesenteric artery is crossing the anterior surface of the left renal vein, so that has to be kept in mind. Anything which is crossing the renal vein has to be on the left side, has to be taken for a superior mesenteric artery unless and until proved otherwise. Okay, inferior right renal artery is usually originating from the right side of the aorta, below the left-sided renal vein. So that is the triangle where the renal artery is originated, so that can be injured. And on the right side, of course, inferior vena cava can be injured. Thank you very much for watching. I hope you liked this lecture. Thank you very much. See you in further lectures on laparoscopy. Thank you very much.